Thank you, Jax. Thank you, Dr. Krishnamurthy, and all of you who are staying back late. And I will not take a lot of your time because a lot of these things have been said, how to control. Actually, we know a lot of it, and we have to act. That's why I have actually brought this book. This book has a chapter which was a DBT brainstorming session, how to control hemoglobinopathies. One of the table of Dr. Roshan Kola was on that, and this was in 1997. Then in 2008, lots of hemoglobinopathy, major experts in India, they contributed chapters in it, in which Dr. Mamenchandi, whatever he said today is also written here, and little bit of what we felt is also written here. So this is already now 8-9 years old. So as Dr. Mamenchandi said, we know enough how to control, how to manage the thing, but now question is, we didn't have the people who matters, that is the political power. Below that, now Dr. Srivastav is here, so the power of NHM, and now we hope things will progress properly. My job here today, because little bit things went topsy-turvy, so basically my job is to say how to strengthen, that means whatever is there, on that how to strengthen the thing. So this is what I feel we can do. These are the goals which we all know, what are the goals of our program. Now these goals actually can be achieved, again this has been told, through several verticals. These verticals are not necessarily isolated verticals, they interact. These verticals are management of the already diagnosed patients, screening program, knowing how many are there in my country, so registry. Then advocacy, very important thing, advocacy group should be there, and I as the President of Hemophilia Federation of India have seen the power of advocacy in getting the patient getting treatment for hemophilia. Then one of the most important thing, most important, is development of human resources. Because I gather one of the Air Force Air Marshal said that I can buy 200 plane tomorrow, but I cannot get 200 pilots who can fly this plane and fight the war. So one pilot is costlier than 200 planes. So question is, these resources cannot come overnight. They have to be developed over time. Then some infrastructure need to be there to communicate with that. Research and future progress, as my Director General has said, ICMR Director General, we need some of them which could be of different types. And finally, whatever we are doing, we have to assess whether we are going on the right path or not, and they are interacting. These are the verticals we have to look into. Now what we have? We have 400 medical colleges, 2,535 NACO assisted FDA recognized blood banks. Actually blood banks is increasingly becoming an important area where you can know how the health of this population in your country is, because they give you easy access and you can do that. We have 750 district hospital, 4,900 community health center in the country. This is 2012 statistics, we have something more now, and 25,000 primary health care centers in India. So this is we have. And these are the distribution, as you say, that it is quite evenly distributed, the 400 medical colleges in India. About 215 are government medical colleges and almost equal number are private medical colleges. So they can be harnessed. And meanwhile, our previous Director General in ICMR thought that medical colleges are not doing enough research. So he paid them 60 million rupees each to almost 100 medical colleges to develop a core research group, which also can be harnessed to develop molecular testing, because all these instrument has been given to them, scientists have been given to them. So these are the medical colleges who have these things already. This figure you already it is very well known about distribution of state in India. Now question is, whenever we want to begin something, what drags us is our 125 crore population and huge size of the country. One of the good point, even if we say that sickle cell is distributed everywhere, it is not restricted among the tribal, it is among the, but largely it is restricted in 10 states, mainly, and there could be some spillover in the neighboring states. So largely in these 10 states where we have 302 districts, 11,000 primary health centers and 2,700 community health centers. So these are the infrastructure we have. Now how can we strengthen? Management, as we discussed and previously also discussed, has to flow in a hierarchical manner. So basically individual also has to know these are the diseases which are lifelong diseases, and in this disease it is not like malaria or typhoid that you have given some tablet and disease has gone away. The disease will be there continuously. So the patient has to know how to manage himself or herself. So this is a very important part of the story, and here a patient's group, as Mr. Ramteke is here, the patient's group can take a because in India doctors are extremely busy. They have very little time. So here patient's group can take a leading part, and in addition to the advocacy program, they can also advise, because when we discuss, I actually wrote a chapter on future of medicine in one of the books, and basically the future of medicine has been described in 4 words. It should be personal, preventive, participatory, and another one was there, I have forgotten. So basically it should be personal, predictive, participatory, because participation is very important. Only doctors are not important. Other players are also there, they have to be there. And this hierarchical thing has already been discussed, that primary health center, district hospital, tertiary care hospital, then apex center. Now strengthening is needed. At each state there has to be one apex center where basically all the programs can be integrated, the clinical trials can go on, researches can go on, training can go on, and on that I think NHM has taken the first step. They are actually empowering one center in each of the states. They have started already. Then screening, again we discussed how the screening can be there. It is also should be hierarchical. Certain techniques can be available in primary health center, certain should be available in district medical college and other level. And in all these levels, we need to put some more manpower, because already in primary health center that poor doctor has to do so much work that he has very little precious things left. I have written another paper also which is going to be published, because there has been a lot of crying that there is no doctor in primary health center, doctors do not want to go into primary health center. What I found surprisingly, that in 24,000 primary health center, on the given strength of doctor, only 10% vacancies are there. This distribution is not uniform, but overall in primary health center 10% vacancies, where in technicians you have 35%, 36% vacancies. 36%, 37% technicians are not there. So there are important problems there which needs to be sorted out. Now coming to the registry. Unlike the hemophilia registry which we have created by the Hemophilia Federation of India through 76 chapter of hemophilia, and this is an NGO. So we have about 24,000 hemophilic. The registry is situated in St. John's Medical College. I personally feel this has to be taken over by ICMR or some other organization. But for hemoglobinopathy, things are more difficult. You are having many more numbers, and it has to flow from government organization. So the registry has to be at the state level, flowing from district to the state headquarters. So once already we have all the state details are available, here actually my past institute, NIIH of ICMR, they can come in and integrate the data and can formulate how these things can go on. So ICMR can put their effort and money on integrating this thing. NHM can strengthen the thing at the district level and at state level, and it can flow like that. And initially I have seen while making the hemophilia registry, they wanted to capture everything. Which joint, how much involved, what is the, so don't keep it so complex. Initially we need actually more in terms of numbers, more in terms of problems. So initial part of the registry should be simple, and nowadays softwares are possible which can later on take over the other part of that, and here we need to put for registry people some more stuffs into that. Advocacy and IC is very important at all levels, with encouragement to form patients group. I am repeatedly telling patients group, patients group, patients group, very important. They are the main pressure group who can make things happen. Extremely important, and these patients group can be involved in various kinds of program along with the doctors. I'll tell you what happens. Actually, because I was with the hemophilia group, I know. In hemophilia, we have a group which we call the chapter key person. In each of the patients group, you can have a key person who is actually interface between the patient and the hospital. Many times patient don't know where to go, what to do, but this chapter key person can take and interface that. And chapter key person's job almost like mothering the patient. So they can do almost many jobs, raising the money, putting the job, and we have given them the training of a management training in different parts. Even the World Federation of Hemophilia gives such training. So then the CSR activities to be encouraged. We have Moha and Mini Ratna companies. Each of the companies can take one state and can help it. Activity to be integrated with the tribal ministry, PWD and other elements. I am talking of PWD because we have talked of so many things: hydroxyurea, folic acid, pain relief, curcumin, cannabis. But one of the very important thing which is often absent is pure water, clean water, which the sickle cell anemia patients often needs. Even the carriers also need, because of the isosthenuria, they lose water, and in many of these tribal villages, potable water which is clean is not available. So that itself has to be done by the PWD and other ministry. It is a very important part of the management system. Education and Ministry of Communication to broadcast and to at least include a small chapter in the class 9-10 textbooks about the common genetic disorder is to be there. I don't know, when we were school children, we used to have in our general science what to do when somebody drowns, when somebody gets fire. Those chapters have gone. So if somebody's clothes get fire, what to do? Respiration, how we will have give. We have all read in our general science book in standard 7, standard 6, standard 8. This is no longer there, but we need similar kind of chapter relating to this at 8, 9 standard is needed. Human resources important, I have already talked. Development of infrastructure, all these will need development of infrastructure. Then what ICMR can do along with that is research for future progress. One is a basic research, because there are a lot of things in this thalassemia. In this 2 days meeting, we have heard how the HEM is involved in creating crisis. Basically, in vascular biology, almost a revolution in sickle cell anemia and vascular biology is happening. It also may allow us to look at the both sides, how you can do vasoconstriction and vasodilatation, both. Cardiac thing we have heard from Dr. Poonam Malik. You have a bulky heart with a lot of extracellular matrix in it. Whether that part is due to only hyperreninемia or hyperreninемia or something like that, we have to see. Operational research is important. Dr. Kate is sitting here. Lot of ethnomedicines are there which have been tried. Bildopatra and all these have been tried, but they have not been seriously investigated in terms of, Dr. Kate has done some work on Ayurvedic and other medicines. So in our ethnomedicines also there could be some leads, and that we should study. and continuing epidemiological studies, because hemoglobinopathy map is a dynamic map. It is not, it is an ever-changing map. 10 years back, 20 years back, there was not many hemoglobinopathy in Bangalore. Now all people from eastern side have reached Bangalore for jobs. So they have carried with them the hemoglobinopathy. So a state which didn't have hemoglobinopathy now have hemoglobinopathy. So basically the dynamic situation in which people's movement is there, and we must record this progress through our publication. And there should be a valid measurement of progress, whether we are progressing or not. Prenatal diagnosis is a very important one to do that. And while we have been working in NIH over the years, I have seen many innovative ideas which can strengthen in different parts of the country related to sickle cell. For example, I found in Kerala, Wayanad district is the one where sickle cell is common. Patients were not coming for follow-up. So what the doctor started, they started giving the patient 3 kilo rice, 1 kilo lentils, if they are coming for follow-up. Because this was giving them a nutrition also and a positive feedback that if they come, they will get this. Unfortunately, this project has to be stopped because it was in a project mode. It was not in a permanent mode. So it has to be stopped. So this was a very interesting thing. Dr. Mamenchondi said one line which also I agree, that the people who have this problem, they have to own the program. They have to own the program. You see in Nilgiri Hills. In Nilgiri Hills area, there are, from the population itself, doctor has come. There are Nilgiri Hill Tribal Development Committee. In Nilgiri Hills, there are hospitals, which is manned by the doctor who are from the same tribe. And they look after sickle cell anemia patient in their own tribe. So that is one. I had the opportunity, because my name ends with A. My name is Kanjaksha. My name ends with A. So if you don't see me, many times in literature, they mistake me as a female. So what has happened, actually you can see that. If you go and open Google and see Leelabati's daughter, that means lady scientist in India, my name is there. So basically, I was with Indian Women Scientists Association. And I went in some areas of, tribal areas of Maharashtra, in that, again, for looking for various kind of diseases, tuberculosis, hemoglobinopathy. There we found out that one of the way to make them own is select one of them. In the village, you select one who can be a contact person, who can send the message and who can do this. So this was something I found from Indian Women Scientists Association. Then Dr. Italia's group in Valsad, because patients were not coming. So what he did is that he gave mobile telephone to all the patients, because patients were not coming in. So, and in a group mobile, the government paid the money, that whatever expenditure on mobile will happen. So you have an anchor person to whom the whole village can ring up that I am not feeling well. The Gujarat system has been such, if the mobile rings and it goes to the government, a doctor actually sees that fellow within 24 hours. 24 hours may be a long time, but for India it is quite short, particularly when it went. So there are many innovative ways each of the people have done to improve that, and from that the people who matters, that is our NHM and others, they can get the idea and develop this program. Already we have an infrastructure, we have to add little bit and we can do great work. Thank you very much.